All will be revealed. It's really a pleasure to be here. I've had a wonderful time. I have so many people to thank. Dan and Pat, my good friend Sue, who I've known since my days in Boston. And let me say that this talk is a little bit like a mashup. I really didn't know what a mashup was until I watched Glee. Now I understand. But Dan made it possible for me to talk about my own career path, which combines medicine and journalism. At the same time, I thought it would be interesting to you to learn about some relatively exotic diseases that we actually see fairly commonly in Los Angeles, or at least I do, because I'm the tropical medicine specialist in town. And so you can tell me at the end if it all works. It's a mashup. But here is the first slide. I myself am a fourth-generation Californian. So I grew up in Los Angeles. My father grew up in Los Angeles. And I'm sure when you think of Los Angeles, especially you budding journalists, you think of Hollywood and you think of, the iconic view of the palm trees and the entertainment industry and many other things. But we also have some diseases that I think will be highlighted in this talk. And I want to just give you a bird's eye view of these diseases, some of the clinical milestones, some of the remaining challenges. At the same time, I'm going to weave in my own journalism and read some excerpts of medical stories that I've written about patients with these diseases. So I may be shuffling a few papers. But how did this all come about? I was probably not the obvious person to go into medicine. I always was very interested in writing and communications. I was a history major, but I got the medical bug when I was in high school and studying biology and working in a hospital. And I got the tropical medicine bug between college and medical school. I spent the summer in Haiti. And back in 1972, and now you know how old I am, it was not very common for people to go to a place like Haiti. It was a tremendous eye-opener for me. This is actually a pretty, lovely scene of what appears to be a colonial town or city, Port-au-Prince. There were a lot of sinister elements. As you probably do know, there was a dictator named Papa Doc Duvalier. He had died the year before. His son, Baby Doc Duvalier, was in power. He was 19 years old. And even to get a travel pass to go to the mission hospital where I worked for most of that summer was a very complicated and kind of scary process. We often saw armed militia in Haiti. At the same time, it was a very lovely group of people that I met, and extreme poverty completely turned my world upside down to see that. This is the waiting room of the hospital where I worked, the Hôpital Le Bon Samaritain, a town called Lambay, near Cap-Haïtien. And, I was 21 years old, and every day somebody died in that waiting room. So talk about, a powerful experience. We're going to come back to that waiting room when I start reading some excerpts. From there, as Dan said, I moved to Chicago. I'd always wanted to, I wanted out of California. I wanted to really experience the world. And I ended up at a very happy place for me. For 8 years, I was in Chicago at Northwestern, where I did my medical school and my internal medicine training. Not exactly tropical, but they very much encouraged me because I had already decided that I was going to go to the London School of Hygiene and Tropical Medicine. And here's a picture of that institution. If you're in London, it's worth visiting, if only to see the beautiful brass vectors, in other words, the insects that transmit diseases like Leishmaniasis and malaria on the second floor balustrades. So what were some of the other tropical way stations? I chose to do my infectious disease training at Tufts New England Medical Center, partly because they had one of 4 Rockefeller Foundation grants to study what were then called the Great Neglected Diseases. And it was a perfect combination because I did clinical training in infectious disease. So you can add up the years. This is like a 12-year span. Finally, I did return to Los Angeles, which, as you know, is my home. And I became the chief of infectious diseases at the smallest of the 4 county hospitals in Los Angeles, which was actually a pretty exciting job for what I would call a medical youngster. And this was LA County Olive View Medical Center, which you can see on the screen. It had been displaced by a major earthquake. It was actually in kind of borrowed quarters in the San Fernando Valley. And it was a haven for immigrants and people who often spoke different languages and brought with them exotic diseases. And I was ideally, trained to see those patients. So that was a great opportunity. And then about 3 years later, I was recruited to UCLA. But to the main campus to start travel and tropical medicine related activities. And I've also always worked on the upper campus and taught undergraduates global health, sometimes working with other social scientists, economists, policy related projects. I've had a very eclectic career. But the journalism piece, well, I didn't put in a slide about it, but when I moved from the county hospital to UCLA, I had some free time and I found an ad in the New England Journal of Medicine for a medical editor at Lifetime Television. Lifetime Television was one of the earliest cable stations, and they were based in New York, but they had about 50 people working in LA doing medical television. All day Sunday was medical television. And I answered the ad and walked into a world that I never knew about. Met my future husband, who is a very outstanding documentary filmmaker, worked with top-notch journalists, kind of moved up the ranks from being a medical editor, glorified fact checker, to a writer, joined the Writers Guild, ended up being on camera, doing on-camera reporting, went to CDC and interviewed people. So I did that for several years. At the same time I was recruited back to UCLA. I was really juggling two careers. And I later segued to print journalism, wrote for the LA Times, wrote for Discover Magazine, did a lot of magazine and newspaper work, and continued to grow as a writer. I really wish I had the opportunity that all of you have to study journalism properly, but I was kind of an apprentice. I got my training on the job. And I do have to say that I was somewhat of a natural writer. I had always been interested in writing, and I was always a great reader. So these other photos, it's just a collage. Of course, I've spent a lot of time going back and forth to developing countries. I'm now in my 60s, so I'm not going to give you the list, but some of it for filmmaking, some of it for medical education. A few other influences on me. I will say I'm borrowing a title here. By the way, I borrowed a title earlier. I don't know if you saw One Tropical Doctor's Beginnings. Pat's nodding her head. That's really borrowed from Eudora Welty, One Writer's Beginnings. And Tales of the South Pacific is really borrowed from James Michener. My father was a very young company commander in World War II on Guadalcanal in the Pacific. And he was there for a year until they finally forcibly removed him because he was so afflicted by malaria, which was, of course, a huge problem during World War II. And I'm going to now start by reading a little excerpt from a piece I wrote for Scientific American, a book review actually, a book about malaria, the history of discovery of malaria treatment. But this comes directly from my dad, who sadly, but not surprisingly, passed away about a year and a half ago at age 98 with an excellent memory. So I'm very blessed to have been able to tap into his memories. Guadalcanal, November 1942, another night of war. Above ground, the air buzzed with mosquitoes and enemy ordnance. In foxholes, weary men in boots, fatigues, and steel helmets shifted restlessly, counting the hours until dawn. If a soldier on Guadalcanal wanted to stay in one piece, a hole in the ground was the safest place to spend the night. But nocturnal refuge had its price, disease-bearing mosquitoes. For proof, one need only to have visited the hospital field tent. There, by flickering electric lanterns, medics tended delirious patients whose blood swarmed with the delicate rings, crescents, and clusters we know as malaria. So my father was in a high-risk setting, but he saw more people die of malaria around him in those hospital field tents than he saw infantry killed by enemy fire. That left a deep impression, that and the bottle of quinine in our bathroom growing up. Another very lucky mid-career assignment for me was the opportunity to work on an Institute of Medicine committee as an author. I do not have the credentials in malaria to be one of the 12 members coming from 4 continents, but I was hired as a consultant and an author of a report that took 2 years and had the great pleasure of working for 2 years, practically cheek to jowl, with a Nobel laureate economist, Ken Arrow, who is still at Stanford today at 95, and that was a great joy. So that kind of propelled me into the world of policy. These are all the pieces of the mosaic that have combined into my having this kind of hybrid career. And this book actually was, I think this report was fairly influential at a time when there was a renewed interest in investing in malaria, and I'm happy to say that in the last 10 years we have seen fruits of that investment. So I think because I was amongst such luminaries, particularly in the area of malaria policy, that I felt empowered to start doing more original authored work that kind of bridges medicine and journalism. So I'm just showing you a few examples, a piece in JAMA, a piece in the New England Journal, a piece in an infectious disease journal. But I also, because I was a longtime writer for Discover magazine, wrote a piece about malaria for the magazine, a feature, and it brought me back to Haiti. Lambay, Haiti, July 1972. Another morning at Hôpital Les Bons Samaritains, the only medical outpost in a tropical valley with no paved roads, telephone, or electricity. This was the world I entered in 1972 at age 21. From daybreak, patients filled the crude wooden benches of the waiting room. By mid-morning, they also covered the floor. The scene was overpowering. Grandparents with rusty sputum and the rattle of tuberculosis, children with tattered clothes and broken bones, infants with swollen bellies, flaking skin, and mustardy diarrhea. But one of these children was not just undernourished, she was unresponsive. I noticed her skin tone. Among the rich brown faces of West African ancestry, she looked pale. Belle, a missionary nurse whose ancestry was pure Iowa cornfield, hurried over. She brushed a hand across the youngster's forehead, gently rocked her neck to check for meningitis, then pulled down her eyelids. They were paper white. So we saw a lot of malaria back there in Haiti. This is a different piece for Scientific American, and then one of my more recent gigs, so to speak, has been a syndicated column called the Infection Files, where I decided that the public was ready to hear about tropical medicine. I wrote about all kinds of infectious diseases, flu and MRSA and the things that people are well aware of, but I also tried to introduce this kind of global health awareness. And I was very happily surprised in the response of my neighbors and everyday people who would not even read a Discover magazine article or a Scientific American article or watch a PBS special. So I do think that there is a growing hunger and appetite for this kind of journalism. Okay, so that's a little bit about my backstory. I'm happy to answer more questions later on. So obviously, with globalization, tropical maladies are now in many hometowns, not just a diverse big city like Los Angeles. They can show up anywhere. I'm today going to talk to you about 3 parasitic diseases: Chavez disease, Leishmaniasis, and a helminthic disease, larval tapeworm disease, actually 2 versions of it, cysticercosis and echinococcosis. I'm going to try to put a human face on these diseases. And then it's not that Los Angeles is overrun with cholera, but we did have a very famous cholera outbreak that arrived on an airplane. So I thought I would tell you the story of that. Okay, so here's another excerpt from a Discover magazine article, and these stories are based very much on real patients that I took care of in my day job as a doc. Intruder in the heart. Miguel never recalled when they actually began, those feeble, quivering heartbeats that snaked through his chest like a high-speed train. The first attacks were so brief he forgot them as soon as they passed. Then, over time, they came more often and lasted longer, until one day a friend at work saw the whole crazy business, the sweat on his face and the fear in his eyes. He thought Miguel was having a dizzy spell and made him lie down. Soon, Miguel's wife drove up in their truck and took him to the emergency room at LA County Hospital. That's when they did an electrocardiogram, his first ever. This man was in his 30s. There are extra heartbeats, said the nurse, but no sign of a heart attack. The intern on duty added, "You're 38 years old, your blood pressure's great, you don't even smoke. You've got a lot of miles left on that heart." So Miguel decided it was nothing. From then on, he pretended he was fine. 2 years later, he was in end-stage heart failure. He had been transferred to UCLA for a possible heart transplant. He still did not have a diagnosis of Chagas disease. We made the diagnosis. Sadly, he declined the heart transplant, which was very controversial at the time, and he died within months. So what is Chagas disease? First, let's talk about Carlos Chagas, who's a great character in medical history. He first wanted to be a mining engineer, but then he decided to go to medical school in turn of the century Brazil. I think he got his medical degree in 1902. He got a thesis in malaria. He was sent to help with outbreaks of malaria among railroad construction workers who were building the railroad into the Amazon. And at that time, he noticed in these very poor quality houses, these mud and wattle houses, that they were infested with kissing bugs. And he dissected the bugs, and he found the parasite Trypanosoma cruzi. He named it for his mentor, Oswaldo Cruz, for whom the Fiocruz Medical Research Institute in Brazil is named. Chagas stands out not just for modesty and incredible scientific, brilliance, but he remains the only scientist in history, I believe, to describe the host, which were a number of animals, the parasite, the vector, which is the kissing bug, and the human disease, which he then discovered in the bloodstream of patients dwelling in these houses. The very quick biological backstory, I'm not going to show you life cycles, but I just want you to understand that this is a zoonotic disease. The parasite is in the bloodstream of animals, a variety of mammals. The kissing bug is a blood-sucking insect. It acquires the little parasite, that C-shaped bloodstream parasite. Then silently, insidiously, those bugs enter a home, and they can take a blood meal from a sleeping human victim. That person often never knows that they've been bitten. And then something slightly unseemly happens, but the gut of the bug is distended with blood, and the gut has what we call reflex defecation. In the fecal contents are these parasites, and they can either directly enter the puncture site, or they can be rubbed in, and you're seeing a swollen eye. That's actually something called Romagn's sign, where the parasite is rubbed in, and then over days and weeks there's a lot of inflammatory change because there's a parasitic infection brewing in those tissues. So that is kind of the quick story of Chagas disease. There are many people who grew up in different types of housing in Latin America who were infected, never knew it. And then there are some acute manifestations, but most people just go years to decades. And then they have end-stage complications, which generally involve the heart and lead to heart failure. Sometimes nerves are involved, and the intestinal viscera, the colon particularly, can become extremely distended, so that's why you see the megacolon. So, a chest x-ray like this one we see these every day in a county hospital or any hospital, and people generally do not have Chagas disease. So there was a hidden burden of Chagas disease in Los Angeles when I arrived at my county hospital. In 1991, 90 years after Chagas did his landmark work, a major study in the New England Journal of Medicine kind of revealed the tip of the iceberg. This was a study out of Los Angeles with 25 patients who had been misdiagnosed. They had been labeled as having what we call normal ischemic cardiac disease, coronary vascular disease, when swollen hearts and, heart failure. And on repeat testing, they all had Chagas disease. So that was beginning to show us something that was going to only increase. The current state of Chagas disease in the Americas is that, happily, the total number of afflicted people has decreased due to a variety of control mechanisms, including better housing and, removing that interface between the bug and the human victim. So from 18 million, perhaps now 6 to 8 million infected people, but hundreds of thousands of those people have dispersed to other countries, including the United States, Canada, and European countries. So we have a fair amount of Chagas disease in the United States, and there are a lot of challenges around diagnosing and treating those patients. One big issue is, of course, a worrisome lack of knowledge among doctors in the United States. These are not diseases that doctors normally learn a lot about, or if they do, it gets lost very quickly in the mass of other common diseases. And at-risk immigrants often don't know the first thing about Chagas disease. By the way, there are 4 possible routes of transmission, not just the bug that takes the blood meal and then defecates, but also blood transfusion can carry Chagas and cause transmission. There is sometimes mother-to-child transmission, so congenital infection, kind of like Zika and some other congenital infections like CMV, and even foodborne. And this might lead to a practical point for some of you who are traveling in South America. Do you really want to drink that hand-pressed juice? I would advise against it. There have been outbreaks recently associated where the bugs themselves have gotten crushed up in the sugar cane or the guava or the acai, and there have been outbreaks of Chagas, acute Chagas, from a contaminated food item. We still have limited access to diagnosis drugs in cardiac care. We have made progress on screening the blood supply and organ donors, and occasionally an immunosuppressed host who has Chagas will reactivate in some unusual way that we don't expect. And then there's the whole issue of stigma and fear, and I'll address that more in a moment. Other facts about Chagas, just what about the heart failure? Heart failure is really the kind of signature complication of this disease. It usually affects 20 to 30% of people who are antibody positive and presumably have had an infection. And the typical incubation from the time that the parasite entered them and the development of that heart disease can be decades. So that complicates matters. Now I'm going to bring you back to Olive View. Olive View was the county hospital where I started. It is today relocated back on its original site. Originally, Olive View was the big TB sanitarium for LA County. Then it became a general hospital. Then a new hospital was built, and it fell down in an earthquake in 1971, and that's why we had moved to Van Nuys. Now it's back in its proper home, and you can see it's a rather attractive, gleaming county hospital. It is the center of excellence for Chagas disease, I'm happy to say, in the United States. They have treated more patients there than any other hospital. That hospital has 400 beds, and it serves about 1.5 million population and about 40% Latino. So a prospective study was just recently completed at Olive View, and they wanted to decide how many patients who presented with, a big swollen heart that wasn't obviously due to vascular disease had Chagas, about 20%. The mortality in that group was 5-fold greater than in the controls who also had presented with heart failure. Hospitalization rate for heart failure was 2 times greater. This was in the space of a 4-year follow-up. And there were many patients who had what we would call a malignant ventricular arrhythmia. In other words, an abnormal heartbeat that could kill them and needed implantable defibrillators. Can we treat Chagas with drugs? This is an ongoing debate. There are 2 CDC drugs. They are not commercially licensed. If you want to use them, you have to get them from CDC. Available on a compassionate use basis. Again, my old hospital, Olive View, has used more of these drugs than any other hospital in the country. The drugs do help acutely infected individuals. Sometimes we do find somebody who's acutely infected and they are also ill, and they can be fairly effectively treated. But in somebody who's been infected for decades and has these end-stage complications, it's not entirely clear that the drugs help, but they are still sometimes treated. They have to be treated for 2 or 3 months. There are side effects to the drugs. It's hard to access the drugs. There are a lot of, as I said, there's a hidden burden of Chagas disease in this country. People have not been diagnosed, not had the benefit of treatment, and do not have access to what I would call is really the necessary cardiac care, which involves, drugs to reduce heart failure, to treat arrhythmia, sometimes pacemakers, sometimes defibrillators, and sometimes even heart transplants. So there's a lot of socioeconomic issues. These are patients who are often non-insured. Sometimes they're not documented. What about blood safety? Well, bottom line, good news. In about 10 years ago, the FDA did license 2 blood tests so that people who are donating blood, who might have Chagas disease and feel perfectly well, are not going to infect somebody else through their blood products. During the acute disease, we do see a lot of parasites in the blood, but once you're in the chronic disease, you can look under the microscope and it's very unlikely that you're going to see the parasite, although there is a way of amplifying the parasite, and that's by doing this special technique called Xena Diagnosis. You see the person's arm with the little white, trap, That is containing a laboratory-reared reduvid bug that will take up some blood and then become a biological culture system to amplify the parasite. And this was one of the old diagnostic tests. I've even seen it done and done it. Not anymore, but that was something we used to do occasionally to try to diagnose a patient with Chavez disease. About 1 in 4,000 blood donors in LA County before the screening began were positive for Chavez disease. So that's another revealing statistic. But there have been advances in this area, I'm happy to say, and even in Latin America, most blood banks now screen for Chavez disease. And there's a new technology on the horizon, and let me tell you why. I thought it might be important for you to know what we do screen for in blood, because it's not something that you always just automatically know. So this is, when I was training in medicine, we screened for syphilis. Now we screen for different kinds of HIV and relative viruses, HTLV, hepatitis B, hepatitis C, West Nile virus, Chavez disease, coming soon, possibly Babesia, dengue, and the FDA has asked that all blood be screened for Zika, so there are tests in development. This is good news, but it's also bad news. With every additional test, the cost of any blood product begins to go up. So the pathogen reduction technology, which is a photochemical reaction involving UV light and a chemical that is activated by light to inactivate almost all bloodborne microbes. There are a few exceptions, a couple viruses, some spores. This has now been FDA approved for platelets. And when I talk to my transfusion medicine colleagues at UCLA, they expect that these systems will really begin to overtake the classic testing of blood, for economics, if nothing else. So we're hopeful. Look for that on the horizon. Okay, final thoughts on Chavez disease, parting thoughts. Just remember, 10 to 15% of congestive heart failure in at-risk Latino population, in other words, people who've lived overseas in a setting where they might have been exposed, is due to Chavez disease. On rare occasions, we have something called autochthonous transmission, which is a great word if you want to, amaze one of your friends. It just really means that we have local transmission. We have kissing bugs in this country. In California, we sometimes see people who have allergic reactions to the kissing bugs, not necessarily because the kissing bugs are carrying this parasite. But there is also canine, in other words, dog Chavez disease that's been well documented in Texas. So there is the potential for transmission in the US. I wouldn't stay up awake at night worrying about this, but I thought it's something that you should be aware of because it's more about our own backyard. Finally, I am personally concerned that the obstetricians really have not been able to kind of grasp the significance of congenital infection. This remains a worry. There's probably a 1 to 10% risk that an asymptomatic woman who is Chavez infected will transmit this infection very silently to an unborn baby. That probably translates to 30 to 300 congenital infections in the US per year. There was a survey done by the American College of Obstetricians and Gynecologists. Only 9% of their members knew that maternal Chavez disease could lead to congenital infection. 80% had never considered Chavez disease. We have a job in educating not just the public, but the medical community. And this is not said with any type of criticism. It's just something that where popular journalism and medical journalism can come together for a better outcome for everybody. All right, let's move on to Leishmaniasis, named after a Scottish pathologist named Leishman. Another vector-borne zoonosis. So this is another infection which is present in many kinds of animals. It is transmitted by an insect. There are about 20 species of Leishmaniasis, and it has very many diverse manifestations and diverse locales. It's kind of a hard disease to get your mind around, but I'm going to try. Here you see some of the animal hosts, a dog, a sand rat, there are many others. The vector in this case is a sandfly. If you've been to Costa Rica, I'm sure you've seen sandflies. That's a little preview of something I'm going to mention in a moment. The sandfly inoculates the parasite, which is shown in the bottom, and then over weeks to months, in cutaneous leishmaniasis, you may get a nodule that turns into a painless ulcer. Sometimes it heals, sometimes it leads to other rather devastating results. The little child is actually my patient. His father is depicted with the machine gun. He was based in Iraq doing security work, then took a job in Saudi Arabia with his Jordanian-born wife, had this little boy. He got cutaneous leishmaniasis on his forehead, and they actually flew back to UCLA to get treatment. He'd had some treatment that's partly a scab from some of the topical treatment that he received, but he had a happy outcome. Okay, so key facts. We have visceral leishmaniasis, where the parasite does not manifest on the skin but invades internal organs, and then cutaneous leishmaniasis. Total of countries that have leishmaniasis, maybe 100 in the world. So it's an important disease to know about. From cutaneous infection, there can be very disfiguring scars in some cases. This carries tremendous potential for stigma in a place like Afghanistan. If a woman has this kind of scar on her face, she's probably considered not marriageable. So for local populations, as I'm going to illustrate in a story in a moment, poverty, war, and of course poor housing, which allows the sandflies to infest a place where they have access to people. For American citizens, interesting military service and tropical eco-travel. Those are the main risk factors. And we also have leishmaniasis in animals in the US, so it is also conceivable that we could have autochthonous transmission. Now, I'm going to give away a story. My grandfather was born. I have one grandfather who came at age 17 to the United States by himself, and he had grown up in southern Turkey. My ancestry is Armenian, and he lived very close to Aleppo, Syria, which of course is in the news all the time now. So he had leishmaniasis. When I decided to write the story of two Afghan girls who came to my clinic with leishmaniasis, I decided to start with the story of my grandfather. And bullseye just refers to the appearance of the parasite in a tissue biopsy. This green thing is the form of the parasite that's inoculated by the sandfly. These are single-celled protozoan parasites. As a child, I was fascinated by a scar on my grandfather's cheek. "How'd you get that?" I asked, touching the shallow depression as we settled into a comfortable chair to read a book. "Where I grew up, everyone had a scar like that," replied my grandfather, a native of southern Turkey. "First, a fly would bite. Then you got a sore. After a few months, the skin healed, and you never got the sore again." 25 years later, as a researcher in Boston, I learned that my grandfather, with no science education, had grasped the biology and immunology of that sore surprisingly well. But I'm getting ahead of my story. By the way, my grandfather had a very big personality and a good ego. He would be very happy to know that I was sharing his story with you today. Okay, let's fast forward. Kabul, Afghanistan, 2000. To escape the heat, Majiba and Naida Fazli flopped down on a striped mattress in the large open-air balcony of the family home they had not seen for almost a decade. They had been displaced by the ongoing war in Afghanistan at that time with the Russians. 7 years earlier, the Fazli family had suffered a dreadful blow. Mr. Fazli, 58, died of a heart attack, leaving behind a widow and 11 daughters. I kid you not. So in order to get their asylum, they eventually relocated to the US. This family had to leave Pakistan, where they had been living, and live in Kabul for 6 months. Kabul was in shambles. Leishmaniasis was rampant. Sandflies were breeding everywhere. These girls were sleeping on the sleeping porch. It was rather amazing. They were the two youngest daughters, and they both had these huge, crusty ulcers on their hands, and they had had them for an entire year since they had come to the US, and they finally came to me. Not an uncommon story, not a disease that is always diagnosed promptly. So actually, they both did well, but that was the context in which I wrote that story. Leishmaniasis has always been associated with soldiers and war. I told you I would tell you about William Leishman, the Scottish pathologist. He was based in India, and he performed an autopsy on an unnamed private JB of the 2nd Irish Rifles, found parasites in the victim's spleen. So he actually described visceral leishmaniasis, a different parasite, a different pattern of disease. But you can see from the photos that, we have Leishmaniasis in a British soldier in the Middle East in 1917. We have a soldier at Walter Reed from the First Iraq War. We have headlines from the last 2 decades. And there is no doubt that there is a lot of Leishmaniasis now in the area of conflict with ISIL. I just had lunch with Barbara Herwalt at CDC. She is the person who is the Leishmaniac expert at CDC. She is responsible for counseling doctors all over the country and releasing special drugs. Okay, now let's go to the flip side. And here's a story that was in the New York Times, another patient of mine who had a great lust for Amazon travel and adventure. And actually, I would say I see more patients like this. I see several patients every year who've gone to Costa Rica or gone to the Amazon and gotten a sandfly bite. We do worry because there are some parasite species, especially farther down in South America, which can cause some very serious complications. I'll get to that in a moment. Keith Aronowitz first noticed the crater on his elbow after returning from Bolivia. For a week or two, he simply ignored it. Then his friends began to worry. A buddy saw the hole in my arm, recalled Mr. Aronowitz, a photographer and video editor, and said, "Hey, you better see a doctor. That doesn't look right." Okay, he decided, I'll see a dermatologist, and maybe I'll even help her with the diagnosis. He knew what he had. At the back of his mind, he was thinking of a recent National Geographic article. In it, the author also contracted a weird skin infection in South America. And it all started, the writer stated, with the bite of a sandfly. When Mr. Aronowitz arrived at Madidi National Park, the same Amazon outpost visited by the National Geographic author, he too was bombarded by sandflies. Soon their pesky bites left him covered in itchy bumps. Then came the elbow ulcer. In Los Angeles, however, the doctor simply shrugged her shoulders when he proffered these clues. Instead, she handed him an all-purpose cream and glided off. So again, this is one of the problems. These diseases are not necessarily recognized the first time around. So here's Keith. He wouldn't mind his picture being shown. He's gone back to the Amazon many times. I really wanted in the New York Times story to educate ecotourists, try to avoid sandfly bites, educate doctors. And then there was this great treatment dilemma. It took us 2 years to really properly treat this man. His elbow would clear up, and then the ulcer would come back. So we went through certain drugs that are felt to be, appropriate choices. We finally had to resort to giving him a long series of injections of an antimonial drug, which can only be obtained from CDC. Why were we so concerned? Why was I so concerned? Where he had been, Leishmaniasis can metastasize to mucocutaneous Leishmaniasis. It's not entirely understood why. Some people don't even know they've had Leishmaniasis. They end up with these ulcers and these, tumorous growths in their pharynx and their nose. So the last Leishmaniasis story is one that will be published in Discover this summer. And the disease is sometimes called espundia. That is a Spanish term that was first used when it was first described. What I find interesting about this story, this woman was misdiagnosed for 7 years. She, in fact, was from Brazil. She grew up in Sao Paulo. She never knew she had Leishmaniasis, but she came to the U.S. with her husband, and at that time she had a very swollen nose. She was having a lot of ulceration and congestion of her sinuses, blockage, and she even developed a perforated septum. Her face was obviously disfigured, inflamed, and she was biopsied by American specialists, very fine specialists, and this tissue didn't reveal any parasites, which is not that uncommon. And they labeled her with a different disease, an autoimmune disease, for which she received immunosuppressive drugs for 7 years. When you get immunosuppressive drugs and you already have a parasite, the parasite usually flourishes. She ended up finally with a lot of violet bumps on her arms and legs. When they were biopsied, the Leishmania parasite was found. And thankfully, she was able to be treated with this antimonial drug, actually several long courses, and she is basically healed. I think if you did an ENT exam, you'd find abnormalities, but her facial appearance is totally restored to normal, so it's a very happy ending. I have spoken to her on the phone in the last month. Whenever I write a story, this is a little journalism piece of advice, the patients I see are one of a kind. they are recognizable to themselves. We can change their name, we can change certain features about the story, but if they see my name and they read this story, they know it's them. And that is kind of a violation of professional ethics. I always share my stories with my patients if possible and make sure that it's okay with them. Maybe I am going too far. I don't know, Pat can comment at the end, but she was very happy to share her story, and she felt that it might help somebody else. Okay, now we're going to move on to worms, a favorite topic of my colleague here. There's a famous professional article called This Wormy World. Actually, it was based on a landmark address given to the American Society of Parasitology in the 1940s. At that time, Norman Stoll, who was the author of that address and article, estimated that 80% of humans on the face of the earth had some form of worm, usually a nematode. So today the number is fewer. I don't think we really know how many. Maybe not. I was going to ask you before I gave the talk if I should fill it in. When we think of worms that can infect humans, they fall into three broad categories: the nematodes, which are the roundworms, the cestodes, which are the tapeworms, and the trematodes, beloved to Dr. Colley, such as the schistosomes and their leaf-like flukes. I am not going to give you any more background on this vast field, but I want you to think about what might happen if you ingested a tapeworm egg that comes from a couple different adult tapeworms. One is the pork tapeworm, which can live as a giant long tapeworm in a human intestine, or a dog tapeworm, which is a short tapeworm but lives in dogs. When these animals, human and dog, excrete the egg, that egg survives very nicely in the environment. It has a very good shell. It can survive tough environmental conditions. And once it enters our guts, it can move and morph into a larval cystic infection. In the case of pork tapeworm, it becomes a cystic infection, most often located in the brain and sometimes the muscles. In the case of the dog tapeworm, it can enter the liver and other organs, sometimes the lung and others. So those are the two important larval tapeworm blights that I see in Los Angeles, not that uncommonly. Here's the story of a man with the dog tapeworm. And he had come from Iran. He was almost 80. He was pretty healthy. He had actually been asymptomatic. He had been complaining of some right upper quadrant fullness, and somebody had finally done a CAT scan, and he had these enormous cysts in his liver. And of course, at that point, it was making him kind of crazy. So here was the opening. What would you do if you had huge parasitic cysts that could burst at any moment and spill thousands of babies? This is one of the problems with the dog tapeworm. It can implant further cysts if it spills. My new patient, an elderly Iranian who recently moved to the United States, didn't speak much English. He didn't need to. His penetrating gaze, anxious, wary, pleading, all at the same time, revealed his inner thoughts. He had one overriding goal: to make his problem go away ASAP. I also wanted to vanquish his parasitic invader and restore his peace of mind. But major abdominal surgery in a man nearing 80, this is not a small operation on the liver. About that, I wasn't so sure. And then you can just read from the Discover magazine piece on X-ray films, the largest shadow was as big as an eggplant. So he had multiple. And there's also pictures here of the tapeworm egg, the big cysts in the liver, and then cysts in somebody's lungs. Also, these take decades often to develop. Okay, that's a little bit about the dog tapeworm, echinococcal infection. Infection with pork tapeworm larvae is called cysticercosis. This was a very interesting phenomenon that we saw not infrequently when I was first arriving at my county hospital at Olive View. At the same time, we had two key advances. Back then, we did not have a CAT scan machine in the hospital. The CAT scan arrived twice a week in a van, and it looked exactly like this. And through the CAT scan, we could see evidence of these cysts. At the same time, there was a new drug, praziquantel, to treat cysticercosis. Before that, there had been no medical treatment. And later, there was another drug called albendazole, which is probably even better. And then there was a big debate about whether you should treat cysticercosis, because what difference did it make? Well, a lot of patients with cysticercosis have seizures. And it turns out, in some cases, if you treat them, their seizures improve. And so there's often that rationale. But this is what we now know about cysticercosis. Many people have it. And a lot of people are actually kind of asymptomatic. But in 50% of patients who are symptomatic, it is the world's most common preventable cause of epilepsy. That's kind of a mind-blowing statement. Symptomatic infection accounts for about 1/3 of all seizure disorders globally, and plus a variety of other neurologic problems, chronic headaches, and also hydrocephalus where the ventricles are blocked. Global surveys looking at people's antibody status show amazingly high rates of exposure to this. So you do know that a lot of people are asymptomatic. Treatment remains complex. Anti-seizure drugs, steroids, parasite drugs, and sometimes neurosurgery. And I tried to give you 3 examples of how we might manage different cases with different modalities of treatment. Just as CT scans were once considered a luxury, arranging surgery for cysticercosis is still not that easy, even in Los Angeles. My old hospital, all of you, sees at least 30 cases a year. They do not have a neurosurgery service. They did for a while, then they just couldn't support it. The county felt that it wasn't justified to have it. The place where those patients would go is 30 miles away, big county. Yes, you can call up. Yes, you can say I have a patient with hydrocephalus, but you know, it's still not that easy to sometimes guarantee that somebody's going to get a shunt and be treated for what is their most life-threatening complication promptly. So these are just some of the dilemmas I wanted to kind of point out. And finally, surgery for the other form of cystic larval tapeworm infection, echinococcosis, also carries risk. Let's go to the right side of the slide. If you wanted to ask what's the next frontier in global health, one answer could easily be surgery. Surgery, I mean, we've gone through oral rehydration for diarrhea, we've tried to introduce vaccines, we're trying to deworm kids, but the lack of surgical services, or shall we say, you know, the high-risk setting for complex surgery remains a challenge. So would you really want to have your liver operated on in one of these very rustic types of settings where the mortality from the surgery itself might end up being rather high? The other side is another patient of mine who was born in Palestine before it was Israel, probably was infected by age 3 with larval dog tapeworm infection in her liver, had multiple operations. When I met her, she was in her 50s. Her story was that she had come to UCLA because she needed another operation, and she's a rather petite woman. And they removed the cyst, but they also removed so much of her liver that she went into what we call hepatic encephalopathy. She really didn't have enough liver. So she had to get a liver transplant 3 weeks later. I didn't see her then. I wish I had. She got her liver transplant. She was doing pretty well. But nobody put her on the antiparasitic drug that she needed. So 2 or 3 years later, she showed up, excuse me, with big cysts in her lung. That's when I started treating her. She has done surprisingly well. So some people with these diseases do go on and on and on. She's now in her 70s. She's a dear friend. And that's a little bit about her story. Okay, the best strategy for global echinococcus is actually a kind of a lower tech procedure, which is both the combination of an antiparasitic drug and an ultrasound guided aspiration of the cyst. It's a procedure that we call PAIR. You can see why it's PAIR, and I've written this out for you. Percutaneous puncture, aspiration of the fluid, and then you inject a solution that will hopefully kill these budding parasite elements. It can be saline, it can be ethanol, and then you re-aspirate. What's ironic is that I cannot find a radiologist in Los Angeles to do this. It's a procedure that is done in developing countries. It's very hard to get somebody to do this in a high-tech medical center because there isn't experience with it. So that's just an irony. Now, I've reached the end of the time. I was going to talk about cholera. I could do that. It would take another 5 or 7 minutes, or I can stop. It's really, I don't want to abuse my audience. What do you say? Cholera. All right, thank you. I find that encouraging. So here's a little primer on cholera. Cholera, of course, is a bacterial infection, and it's a comma-shaped bacteria. It produces a toxin. The toxin is really the cause of the illness. It poisons the absorption of fluid and electrolytes, leading to the net and very dramatic excretion of fluid and diarrhea, so that people can become extremely dehydrated and sometimes even die in the space of a day. We can culture this organism in somebody's stool, but you have to ask for the right culture medium. So it doesn't show up on the routine stool cultures. You have to think about it. And that is going to be relevant in a moment. There's a classic tropical medicine photo on this slide. It shows a patient, an old-fashioned patient, surrounded by all the glass IV bottles it took to replace his fluid loss. You get the picture. A lot of fluid can be lost very quickly. The very dehydrated child on the cot has tenting of the skin, just completely, desiccated, and there is a hole in that cot to measure the fluid output so that it can be replaced with the appropriate IV or oral solution. By the time you have full-blown cholera, it's not even displeasing kind of fecal output. It's really what they call rice water stool. It's just a slightly milky, watery fluid that just flows out of people. And one of the great mysteries that has been solved in the last 20 years is, where does the cholera organism hang out when it's not in people and there aren't little epidemics or large epidemics? The cholera organism likes brackish water, and it can live in a dormant state in little tiny organisms like copepods or shrimp-like tiny crustacea, and that is its secret reservoir in nature. Okay, so cholera lands in LA. This, I think, is the largest outbreak of cholera in the US in the last century. The story written as follows. Not long after landing, an attendant knew something was wrong. Between gurgles, pings, and cramps, her gut felt like a punching bag. She quickly disappeared into the lavatory. Meanwhile, in a different part of town, a passenger from the same flight was also in distress. Her bowels were running like water. Suddenly it dawned on her this intestinal bug was out of control. In a third house in the sprawling metropolis, a 70-year-old man who had just flown 6,000 miles to visit his family checked his shaving kit to see if his diarrhea pills were still there. Well, maybe he should take a couple. This illness was worse than usual. 3 days later, the flight attendant and the sightseer were recovering. The grandfather was dead. I actually was asked to review the medical chart of this one fatal case, so I know some of the mistakes that were made. But here's the backstory. Epidemic cholera hit South America in 1991. It was the first time in a century that there had really been an epidemic throughout that continent, and within a year, 14 countries were affected, 400,000 people had had cholera, 4,000 had died. So that shows you that there was a medical response, and most people survived, but 4,000 is still 4,000 too many. February 1992, a jet starts from Buenos Aires, lands in Lima, picks up a lunch, it happens to be a shrimp salad, then flies from Lima to Los Angeles with, more than 300 passengers, a lot of crew, and upon arrival already 5 people are having diarrhea. The case count was later proven to be at least 75, 10 hospitalizations, 1 preventable death. Sadly, the man who died, I think the fact that he took anti-motility drugs may have masked some of the diarrhea, but he went to the emergency room 2 or 3 times, and he was a healthy 70-year-old. He was actually a rather famous radio announcer in Buenos Aires. And I know the hospital settled, I never went to trial, but there were so many clues that he was grossly dehydrated. But I think because he was 70, people were fearful. They think, oh, 70, I'm going to be 70 one of these days. And they just didn't give him enough fluid replacement. And when I looked at his x-rays, his gut was distended. He had an enormous amount of fluid in his gut. His electrolyte and blood tests were all over the map, but really, there were a lot of clues. So I feel very personally about this. And of course, it just was not thinking of it. This could happen again. It could happen pretty much anywhere. Cholera is out there. It really was the first global pandemic disease. You know, it started in India, but by 1817 it was beginning to move out. In the 1830s it was in New York, it was in London. And by the way, this book, I think, is a very excellent history of cholera. It just came out, Pandemic by Sonia Shaw. Thanks to better surveillance and global media, we've kind of rediscovered cholera, so we all kind of know the name. You can see some of this WHO data and recent outbreaks. Everybody knows about Haiti, but there's outbreaks all the time. And the good news is that we now have, I would say, a very usable cholera vaccine. I'm showing the picture of John Clemens because he's my colleague at UCLA. He's in the School of Public Health. But he's really been a champion for the development of this vaccine. First developed in Vietnam, then further developed in Korea. And they just completed an enormous study in Bangladesh, where he now works at International Center for Diarrheal Disease Research. And almost 300,000 people were vaccinated in the Dhaka slums, and a 2-dose series conferred 50% protection for 5 years, outperforming household sanitation. But there are still remaining questions. I'm almost done. Who should receive the vaccine? Should it be proactive? There are settings where we know cholera is likely to erupt, but usually it's a reactive response. It's not proactive. So there are very interesting questions that I think that we have to examine as medical professionals, as a society, really, you know, not just the conventional childhood vaccines, but a whole new generation of vaccines. This is one of them. Who pays for these vaccines? They're going to people and countries that largely can't afford them, although this is a fairly low-price vaccine. And how much should we stockpile for the next Haiti? So I leave you with those thoughts, except, of course, the other tropical blight that could well arrive in our own backyard, transported by 1 or 2 different mosquitoes, and a kind of slightly sardonic cartoon. We're always in a kind of a crisis management approach when it comes to tropical diseases. Certainly Zika is deserving of this response. But you can see the cartoon: missile defenses, check; perimeter wall, check; background investigations, check; border patrol, check; retaliatory strike readiness, check; and then just coming in from the side, this tiny Zika appears to be undocumented. If only our lawmakers knew how many tropical diseases we have right now, that would please me very much. So that's the end of my talk, and I hope it was interesting and useful. Thank you for having me.